Hey folks, and welcome to our video on sleep and sleep disorders, a topic which is hopefully near and dear to your hearts, because if you guys are anything like the med students I know, your sleep hygiene is terrible. So let's talk about all the things that we are doing wrong. So why do we sleep? Um, Basic functions, obviously to conserve energy, because you don't really need to be up all the time. There are points of the day where you physiologically don't have a need to be asleep. Thinking back to your ancestors, you can't do much in the night hours anyway, so you might as well conserve some energy. You need to repair injury and restore sort of body, all the things that you use up during the day. And that all comes back during sleep. That happens during non-rapid eye movement sleep, which we'll talk about in a second. And then you also need to consolidate things that you learned or developments in your brain that were made throughout the day. And that happens in REM sleep. You might have heard about those stages. We'll talk about them in a little bit more detail later. In terms of how long you should be sleeping, we at our age we should be sleeping maybe 7+ hours a night. That's going to be different for people, so some people are going to be fine with 6 and a bit hours. Some people are going to need 9 hours or more to sleep. If you are sleeping regularly 9 hours or more, so that means like it's not because you slept for 4 hours 3 nights in a row and then you slept for 10 hours one night. Or especially would also be like more lenient in young adults and adolescents, because adolescents are going to sleep a huge amount because of puberty, and some of that can sort of hang over into young adulthood. If we're looking at an older person who's sleeping for a long time per night and they're not sick, then we might be looking at maybe they have some sort of pathology underlying it. But it's not a particularly strong diagnostic indicator. Again, with stages of sleep, so these measurements over here, so EOG is your eye movement, EEG is your brainwave activity, EMG is your muscle. So you can see as we go down the stages of sleep, we get less and less muscle activity, so less of your actual active body is moving, but your eyes and your brain are working more and more as you go through these stages. And the frequency of this wave changes. You don't need to know the details of this, but it's just a good illustration. The sleep cycle is a little bit more important to understand. So in order to get asleep, you need to go down basically through all these stages, and then you're going to alternate between these different stages with different sort of tendencies. So towards the start of the night, you're going to be going through the full spectrum, and you're going to spend a fairly long amount of time, you can see here, in stage 3 and stage 4. So that's good for your restorative functions, and so your body sort of almost is prioritizing healing and recovery from anything you did during the day. And then towards the later part of your sleep, you spend more time in REM sleep, which is really good for learning. So think about it, if you're only getting 4 hours of sleep, you're denying yourself all of that extra revision time in your sleep. So in terms of how we measure sleep, and this is one of the things I want you to take away, because when these sort of things come up on the exam and in questions, it's usually to do with OSA, which we're going to talk about in a second, and the measurement, so the diagnosis of OSA, and the treatment of OSA. So in terms of measuring sleep, we can do what we call a sleep diary, which basically means, okay, we're going to get you to write down how much sleep you got every night. So that's a bit subjective, as are sleepiness questionnaires. So they sort of depend on how accurate the person's memory is, and then how accurate, how well they are able to get that down. There's actigraphy, which basically means you wear a little accelerometer like the one in your phone, and it detects how often you move. We have, and then the big money, the stuff that you actually want to answer if you ask this question on an exam, is you do sleep studies, which is polysomnography. Sort of in the name, so somno sleep, graphy measurement, poly everything. So they try to measure pretty much everything. You saw on the output earlier there before EEG, EOG, and EMG. We will also check an ECG and your breathing, because that's quite relevant for a lot of stuff we're looking for, especially in terms of OSA, which we will now talk about. There's also central sleep apnea. So apnea just means sort of cessation or breaks in, which we would like to avoid because it obviously doesn't help you get good sleep. Central sleep apnea means there's something to do with the lungs. That's less common, and you guys need to know less about it. What you do need to know about is obstructive sleep apnea, okay? So The basic upshot is that you have an airway here that needs to be protected. So all of this stuff on top of the airway needs to not go back into the airway. So if it does go back into the airway, so your palate sort of slumps down, your tongue slumps down, whatever, you're blocking off your airway, and of course you can't get air in. And so your body's going to freak out and say, I am choking, I'm going to suffocate. And so it wakes up. And you may not be aware of these, what we call apneic events, but they're going to disrupt your sleep regardless. And so obviously you get quite a severe degree of tiredness. And so the classic presentation for somebody with OSA is going to be I can sleep all night and I still wake up tired. So they're not getting good sleep. And like I said, they may not be aware that they're waking up during their sleep. So to them, it might be a black box. They're like, I don't get it. I'm sleeping for 10 hours, but I still feel sleepy when I wake up. And there is an association with cardiovascular events. So you can get hypertension, you can get arrhythmias, and more severe cardiac risk if you have severe OSA and you're not treated. So if you're treated, the risk goes quite significantly back down. Yeah, and then I guess one of the common presentations, not because it's statistically common, but because we care more about it, is you'll get truck drivers. So they'll give you a question, it'll be like some such and such truck driver is feeling much more sleepy than usual. He, drinks X amount of alcohol per day excessively, and is obese, and maybe uses some sort of sedatives to get to sleep because he's been having trouble. What does he have? He probably has OSA. And we're particularly concerned about people like that because if you're more sleepy and you're less attentive during the day, then there's a higher risk of road crashes, and that we really don't want to have that. Okay, so what do we treat? You might have heard of CPAP because OSA is a common condition and a lot of people have been prescribed CPAP for it. And so what that does is it basically just blows air in to maintain the airway, basically. So positive airway pressure means that they have got an open airway all the time instead of having the risk of closure. What I forgot to mention here, which I'll add to the slides later, is that we have a severity scale for OSA. So the general marker is how many times do you wake up during an hour. So less than 5 times an hour is normal. And like I said, you may not be aware of them. So if it sounds weird that you can wake up 5 times in an hour when you're asleep and be normal, it's probably because those are little sort of subconscious events. We start getting to OSA territory when we get to 5 to 15. So we'd call that mild OSA. If you've got 15 to 30 events per hour, we'd call that moderate. And then if you have more than 30 events an hour, then we call that severe. So you can see how if you are waking up more than 30 times an hour, for every hour that you sleep, you're going to have a lot of trouble with actually getting good sleep. All right, so like I said, CPAP, we want to go and do that because if they can tolerate it, that's going to be the best treatment. But a lot of people are like, I don't want to wear a mask when I sleep. I don't like having this big hose attached to my face. And fair play, it is a pretty uncomfortable device. So there are different things that we can do. So as always, we're going to manage risk factors. And so if they're taking sedatives, stop doing that. If they're taking alcohol, cut that down, and hey, it'll reduce their cardiovascular risk in general too. The same goes for obesity. We want to encourage lateral sleeping. So if you think about it, most of the problems associated with OSA happen during supine sleep because you need to be able to have your palate relaxed back down with gravity into your airway. So you want to instead make them sleep on their side. Generally, we don't want people to sleep prone because obviously that has certain problems with the airway. You might have heard of like jaw thrust devices. I think they're more commonly known to lay people. And it's basically almost like a mouth guard that you put in there to try and avoid relaxation back into the pharynx and keep the airway open. If it gets this is like if it is severe, they don't tolerate CPAP at all, or they've got CPAP and it doesn't work, then we consider surgical management. But this is a pretty extreme step to take for OSA, and so there are some things that you need to do. I've said you don't need to know. Frankly, you don't need to know any of the surgical stuff for second year, and arguably third year. Just that you can do surgical management if needed. All right, so leaving OSA behind, let's talk a little bit about movement disorders. And so I should have said before, we split up basically sleep disorders into breathing and movement. So we talked about apnea, which is basically breathing disorders. The only thing that can broadly go wrong with your breathing when you sleep is either your breathing isn't working properly, so central sleep apnea, your lungs are not working, or you can't breathe because you've got an obstruction. So we've also got movement. So this can either be interrupting sleep, or it can just be a pathological thing during sleep. So periodic limb movement disorder and restless leg syndrome, almost like a bit of a spectrum. So restless leg syndrome is the more severe type that we worry about a little bit with patients, because it can get to the point where they can't sleep, and they're just pacing around the house and they cannot get to sleep, and obviously that's not good for them. So it is, like it says on the tin, thinking about causes. of somebody comes in and like, I can't get to sleep, I'm constantly trying to move this leg, I don't know what's going on. You can think about these things. Antidepressants is a pretty big one. And so in terms of stuff that you'll see, iron deficiency, antidepressants, maybe pregnancy, those are pretty likely. Obviously, it's not a common condition overall. It's more common in women. Is that because most of the causes are more common in women? Or is that because it's primarily more common in women? I'm not sure. But you don't need to know too much about that besides the basic idea of what it is, that it's a movement disorder, and obviously the risks of it. And really quickly, we'll talk about parasomnia. So we split them up based on where they happen during sleep. So there's sleep paralysis in REM. That is distinct from night terrors. They're two different things. You can get night terrors, bruxism, which is when you sort of grind your teeth when you sleep, and sleepwalking, all in non-REM sleep. And the last little point that I'll say there is that there's a common conception that you shouldn't wake people up when they're sleepwalking because it's dangerous for some reason. It's not true. Just wake them up. Like, they're sleepwalking, they are asleep. If you wake them up, they will wake up. That is the only consequence of waking up a sleepwalker. Whereas if you leave them sleepwalking, they are very, very liable to go and do something dangerous to themselves. So whether that means going and touching something dangerous, or really, I've at my school, when I was in maybe year 8 or something, somebody's brother basically walked off a roof and died while sleepwalking. So basically, wake people up. There's no reason not to, and really bad things can happen if you don't. And on that cheery note, we'll leave you. All the best.